네, 2024년 7월 27일 EKG 컨퍼런스 시작하겠습니다. 저는 발표를 맡은 강사인 연차 황태현입니다. 제가 준비한 심전도는 다음과 같습니다. 오늘 모더레이터는 박한진 선생님이십니다.
쌤 오랜만에 오셨습니다.
네, 벤트리큘라 바이즈민이 소견을 보이고 있고, TBC 같은 경우에는 2,3-AVF가 포지티브 벡터를 관찰되고 있고, RBB라고 하는 V1S라고 하고,
위치는
위치는 OT에서 발생한 걸로 추정이 되고 있는데, V1, V2에서 트랜지션이 관찰이 되고 있는 것 같습니다. 그러면 RVOT나 뒤쪽이나 LVOT 앞쪽에서 발생할 가능성이 있을 걸로 생각이 듭니다.
쌤
저도
앞으로색 PBC로 보이고 여기들이 비슷하고 트랜지션이 뒤에서 거론되는 것으로 봐. 엘비아 프로텍 있을 것이고
이번에서 LB고 스트리밍에서 풀3에서 떼시고 이런 가능성도 있고 TV
박한진 선생님 말씀하시는 게 하나도 안 들립니다. 좀 크게 얘기해 주십시오.
예, 알겠습니다. 다음으로
네, 다음 자료를 보여드리면 환자는 45세의 젊은 남자분이고 사실은 증상이 없었고 건강검진 중에서 계속 PBC가 보인다고 해서 그냥 건강검진만 받으시다가 5년째에서 PBC가 너무 이 심전도에서 자주 보인다고 해서 그때 리퍼가 됐던 분이시고요. 환자는 한 달에 한 번에서 두 번 정도 술을 마시는 소셜 드링커 정도고 담배는 안 폈고 이전에 마라톤을 좀 즐겨서 했다는 그런 히스토리가 있습니다. 2년 전에 찍었던 심초음파에서는 마일드한 글로벌 하이퍼카네이자 오브 LV가 좀 보이고 LV 엔다이아스톨릭 디멘션이 66mm로 커져 있고 LV 시스톨릭 펑션도 EF 50으로 약간 모데레이트 마일드하게 조금 이렇게 떨어져 있는 양상의 이센트릭 LVH 보이고 있었습니다. 그래서 이때 이제 이밸류에이션을 위해서 24시간 홀터를 시행했고 non-sustained VT도 한 4비트에서 많게는 6비트까지 보이는 게 있었고 PBC 버든은 한 49% 정도였었습니다. 여기서 혹시 어떤 매니지먼트를 하실지 박한진 선생님께 문의드립니다.
일단 제 생각에는 OT PBC인데 PBC 버든이 49% 정도로 많이 있으니까 PBC 뉴스드 카디오마이오패시가 생길 개연성이 많은 퍼센트 정도여서 당연히 처음부터 저 같으면 약물 치료를 먼저 시작을 할 것 같습니다. 다른 혹시 조수훈 쌤
아까 그 카디오그래피 상에서도 물론 LVF가 프레저베이션 돼 있긴 하지만 10% 정도로 보더라인이 있었고 PBC 버든도 상당히 높은 것으로 보아. 말씀하신 대로 오토메이티시 가능성이 높기 때문에 약물 치료 포함해서 방실로 보장이 안 됐을 때 인적 그대로 적극적으로 고려를 해봐야 될 게 있습니다.
So, good morning, guys. Can you hear me?
예,
아, 네,
들립니다.
안녕하십니까.
Okay. So you're talking about the ablation. Then we want to think about the mechanism of tachycardia so that you can plan better your ablation procedure, correct? So you're showing the tracing of non-sustained ventricular tachycardia. And what do you think about this tracing based on mechanism of tachycardia? Let's think about this first. What would you say this mechanism is tachycardia? So you have arrhythmia, you have automaticity, trigger activity, and reentry. So all three can have a different approach of how to ablate this or how to even treat the patient. So what is the mechanism of this tachycardia? It wouldn't be important to you think about it before you're discussing ablation, this patient?
I think the couple interval PVC and first bit of non-sustained VT is exactly same couple
Same, yes.
interval.
Agree.
So it could be a triggered activity rather than automaticity, because if it is automaticity, we call it so-called parasystole, but exactly in the same coupling interval PVC or non-sustained VT might be a preferred mechanism of triggered activity. My question is why this patient, in this EGM, Holter recording, why the PP interval is so fast? So in which situation the patient showed this kind of arrhythmia? That is my first question. And my recommendation is, before deciding medical therapy or ablation, I would like to recommend quit alcohol drinking and coffee first.
So let's explore further Dr. Park's question. If you look at the first bottom tracing, first 3 QRS complex VT is not a copycat almost same as the third group. So you have a 3 bit of a non-sustained ventricular tachycardia compared to the last 3 one. The patterns are almost the same, except what's the difference? What is the difference there? Which might explain Dr. Park's question. First of all, patient does have a VA conduction or no? You measure the PP interval. What do you think?
Looks like no.
Yeah, there's no VA conduction. So does that matter when talking about symptoms of a non-sustained ventricular tachycardia, there's a VA dissociation or VA conduction? Is that matters? Yes or no? It's an important question. It matters quite a bit. When you have a non-sustained ventricular tachycardia, especially elderly patients, VA dissociation can cause more dizziness, weakness near syncopal episodes because of interaction between dissociated atrial ventricular contractions. Imagine the last bit. If you look at the last third bit, your atrial ventricle is going to activate same time. Then what would be happening there? Your valve, mitral aortic valve closed, and then your both ventricle atrium is squeezing. Then what happened? Your neck vein is going to be distended. Your brain flow going to be shut down. Cardiac output going to be down. Okay? So in ventricular tachycardia, even the rate we emphasize quite a bit. Another mechanism of patient feeling dizzy, lightheaded, hemodynamic instability, particularly in the VA dissociation complex. So we are colliding basically contraction against a closed or shut valve. So this is one of the characteristics of this patient have a non-sustained or sustained ventricular tachycardia with a VA dissociation. Okay, this is one thing that the fellows should know. Second, why this patient, if this is a trigger activity, okay, leads to first to three and last to three complex you pointed out, rate gets faster as the other interval gets shorter, right? And then tachycardia terminate, right? Then if you measure the PP interval, appears slightly longer than other. Go to the last complex P, right? That guy to the next P. Next P, sinus, yes. Is that longer than other beats or not? If it's so, why the longer? That's another question you need to answer. Okay? Is it longer, right?
네, 저도.
Yes. What's the mechanism? So we are interested to teach you mechanism of tachycardia as well. We are not just trying to teach you just what you see in the tracing, because what matters ultimately is a pay for patient standpoint of view. Why I'm having these symptoms, why I'm feeling so lousy, okay? If you don't know this mechanism, you cannot address those issues. So it is equally important knowing what you're looking at it, which will ultimately result in treatment of patient. Anybody know the answer why this PP interval? So did you measure PP interval all P wave complex? Have you measured it?
다 측정해보진 않았었는데,
Okay, so I want you to measure PP interval of all of them. See what happened. Do they get progressively shorter or longer? What do you say? Only that complex get longer. So next time when you do this, and I recommend you, encourage you, measure PP interval. Okay? Clearly the last one is longer. Second one, it gets shorter, you think? And then get longer. Yeah,
요
that's
비트는 더
shorter,
짧았는데.
right? That's shorter. And have you heard about the ventricular phasic P wave? What is ventricular phasic P wave? Anybody knows? I guess you guys need to go read this.
When the atrium and ventricle contract together, it stretches the atrial, the mechanoreceptor, and change the heart rate
Right.
because of autonomic influence. But
Yes.
generally, after the AB's the simultaneous contraction, after that event, the PP interval prolonged. That is
Right.
so-called ventricular phasic atrial arrhythmia. But in the
last
green the line is in the middle of the non-sustained VT. So
beat prior to that is your P QRS almost colliding. So beat just before, yeah, that first beat, yeah, that one. Okay. So there's a mechanism sign of arrhythmia, several mechanisms. One of them is a ventricular phasic P wave. Okay. First thing you know is that the normal sign of rhythm young man started on arrhythmia due to the vagal tones, heart rate speed up, slow down during the respiration, inspiration. That's a physiologic. Second sign of mechanism sign of arrhythmia is a ventricular phasic P wave, which Dr. Bach described. Happen to be abnormal. Okay. So it is important to know that the sinus arrhythmia exists abnormal and normal one. Normal ones are respiratory related. Abnormal ones are related to usually tachycardia with the VA dissociation, different coupling. Okay, so that's what you're describing. Now, what's the mechanism of tachycardia then? This is a still trigger activity, automaticity. What do you say? Why the acceleration stops? Even though you cannot answer this 100% with the trigger automaticity, at least the focus that firing appears to be having exit block pattern. Accelerate and blocks. Accelerates and blocks. So if you're thinking about the ablation strength point of view, what kind of mapping you're going to use? Earliest activation, or this is going to be, if it is a re-enter mechanism, you're going to have to find the what we call critical conduction delay area, so forth. So trigger automaticity patterns, we treat the same, right? You just find the earliest activation site with the 3D mapping and ablate the focus. And that probably what you're thinking, I hope. Anything else we want to comment about this tracing?
Now for this tracing, but I would like to raise the question, clinical question about this patient. Somebody told that this patient, somebody will consider that medical therapy, this patient in the borderline reduced ejection fraction and non-sustained VT, but asymptomatic. So in this case, what kind of antiarrhythmic drug do you consider? 박한진 선생님이 아까 얘기하시지 않았나요?
EF
EF는 50%.
So what kind of drug will you try?
아무래도 EF가 낮고 이미 PVC 인듀스드 카디오마이오패시가 있기 때문에 당연히 먼저 베타블로커류를 먼저 사용을 하고 안 되면 아미오다론을 써보지 않을까 싶습니다.
So as far as I know, the antiarrhythmic drug for the patient with asymptomatic non-sustained VT is class 3 indication. Do not use. So you're right. I think that I prefer to use beta blocker, but the amiodarone is toxic drug for long term. So we need to think twice before prescribing antiarrhythmic drug in this patient. If the PVC suppression 목적으로는 AAD를 쓰는 게 justify가 되는데 non-sustained VT suppression 목적으로 바로 antiarrhythmic drug 쓰는 거는 가이드라인상에도 맞지는 않습니다.
Okay. Now this patient, Dr. Bach commented, and your answer is correct. The reason is, look at what's the sinus rate, this patient. Is sinus tachycardia or upper normal? Is sinus tachycardia, right?
네.
So beta blockade is probably also important, but Dr. Bach says abstinence of alcohol and caffeine probably the good thing. Even despite that, patient continue to have non-sustained ventricular tachycardia. Yes, beta blockade, because the patient developed this type of a behavior only during the when sinus rate is accelerated. That suggests that the patient have a high elevation of catecholamine. And obviously, you're going to rule out other causes like hypothyroidism and so other those issues. So you need to work that out, even though the patient have a history of alcohol and caffeine use. Okay. Once exclude those, then you may consider use a beta blockade for heart failure therapy purpose, LVH, and then sinus tachycardia. Okay. All right. Anything else? So you all agree that the VT coming from the outflow tract, you all agree they come from the left side or right side? Sorry, I joined you guys a little late. What was the bottom line?
저희들이 생각하기에는 RVOT
RBOT. Okay. So if you look at the 12-DCG, how come V1, V2 is so skinny? I mean, it's narrower than almost normal sinus rhythm. So how do you cope with that? RBOT usually that narrow QRS complex and then V1, V2. And then transition is rather early, right? Only when you can have such a narrow, very narrow QRS complex V1, V2 in outflow tract PVC. And the axis is relatively preserved, like a normal QRS complex almost, over axis of QRS complex, the PVC. So what is the implication of that? So you could only possible if you have such a narrow QRS complex. First of all, if you think you have to activate the Purkinje network very quick. In other words, PVC have to invade conduction system very quickly. Otherwise, you wouldn't have a narrow complex. Second, your transition of a V1 such it become even narrower, what it is. You have to activate right left ventricle together, especially right and left bundle. Normally you have a slight delay in right bundle activation in physiologic setting, correct? Because left ventricle activate because the proximal portion of the right bundle is isolated. Until they reach the right bundle, you have to have some degree of a transseptal conduction in the ventricular septum. Is this patient has a transseptal conduction? B1? Does not appear to be, because even narrower than sinus rhythm. So you wonder, this focus could be a little bit lower in the septum, right at the center of the activation of the both right and left bundle together. So it may not be right or left, what I'm trying to tell you. This is septal PVC, very close to conduction system, okay? So ablation, in other words, going to be not that easy. That's something that you also need to consider in your conclusion, because this is a relatively young man, asymptomatic, even though your non-sustained BT number of PVC is very palatable for ablation. Some of the ablation people, dying to ablate this. The risk associated can be too high, which you ultimately should, consider in your procedure planning and decide whether you want to ablate this or not. So, like Dr. Bach says, medical conservative management first. Only then you've done everything else, then you're going to take this patient to the lab. That's what I would do. Okay? Any other comment, please? What I'm telling you make sense?
예,
Okay. Please add other comment about this. Anyone else want to talk? Okay, then let's move on.
네.
Thank you. Wonderful discussion.
사실 아직 끝난 거는 아니었습니다.
Okay.
이제 뒷얘기가 더 있는데,
Mhm.
그래서 교수님께서 말씀 주신 대로 이분 금주를 굉장히 교육을 열심히 하고, 그다음 베타블로커와 AC 이니비터, 고혈압이 약간 130에서 140 정도 있어서 3개월 정도 약을 투약을 했는데, 그러고 나서 찍었던 심초음파에서 EF 52%였고, 폴터에서도 여전히 PBC 45%에 넌서스테인드 VT도 3비트 나와서
Okay.
다시 어블레이션까지 했습니다.
Okay. So where did you ablate?
어블레이션 위치는 여기 보라색이 이제 LCC,
Mhm.
여기 이 초록색이 이제 NCC인데 이 LCC 빌로우 밑에 쪽에서 3번 정도 지지고 나서 없어졌습니다. 그래서
So you're very close to his bundle, right?
예,
Okay. That makes sense. All right. Good work.
예,
Yes. Wonderful.
그렇게 이제 사이너스 리듬이 왔는데 안타깝게도 그 23년 10월에 다시 재발을 해가지고 PBC가 27%로 되고 카베딜롤이랑 발설탄까지 쓰고 12월에 45%까지 올라서 플래카나이드 클래스 1C 드러그까지 썼는데도 31%여서 EF는 좋아졌지만 아직 LV 엔다시스톨릭 디멘션이 커서 리드 어블레이션까지 진행을 했는데 사실 이때 심전도는 이렇게 좀 변했습니다. 의원이 조금 더 와이드해졌고 V2도 이렇게
Mhm.
더 와이드했었습니다. 그래서 그래서 이때는 어블레이션 좀 굉장히 많이 했는데 LCC 아래쪽에서 굉장히 많이 지지고 그래도 터미네이션이 안 돼서 에피카디얼 CS 쪽으로 그레이트 카디오 베인 쪽으로 지져서 여기까지 어블레이션을 했고 굉장히 이 사이에 있다고 생각을 하고 한 6.5mm까지 굉장히 좁혀질 때까지 어블레이션을 많이 지졌었고 그 이후에도 계속 PBC가 한 90분 정도, 90초 정도 지나면 다시 PBC가 리커해서 어블레이션장에서는 더 어블레이션 진행 안 하고 일단 나왔는데 다행히 환자가 퇴원하기 전날 이제 찍었던 심전도에서는 사이너스 리듬으로 잘 돌아와서 이제 추후에 이제 외래에서 팔로우할 예정입니다.
Okay. So then let me ask this question now. You had a two ablation done this patient, and the end point was not very clear whether it's successful or not, correct?
예.
So if a patient recur, what would you do based on all the information that we have? Are you going to ablate again, or are you going to do different approach? So it looks like you did an extensive ablation on the, summit area almost even, looks like. And so based on the data, we know this thing involving probably closed conduction system, and then it has a different axis. So you agree probably intramural focus. So the next planned procedure is what?
다음
음.
한다면 트리두를 만약 하게 된다면 바이폴라나 아니면 시물테니스 유니폴라를
Okay.
해야 되죠.
So, right. So I think you probably need to do some more aggressive approach, but the also mapping should be considered now. Your second procedure, did you do cardiac vein mapping beside the coronary sinus, anterior cardiac vein, and great cardiac vein? I see your catheter in the great cardiac vein, your CS catheter. Have you able to?
CS 매핑을 전체를 다 하진 않고 이 근처에서 주로 매핑을 해요.
Right. So I think next time, if you want to ablate this, probably you will have to use a small French catheter to insert into the cardiac septal branch, as well as if there's a communicating vein, you want to put up between the, outflow tracks. So that way you will you really need to have a more precise mapping if you really want to do it, because looks like your mapping, looking at the map, is not very reaching the rotating location of the focus close enough to target, because that's why you end up running a lot there. So that's probably what you can think about it. So a more aggressive, deeper lesion forming technology plus better mapping. So that would be a next thing you want to do. Okay. Anybody else has anything else comment here?
I think this patient may have another kind of progressive cardiomyopathy because the LV chamber size is unusually big. So in the guideline, there says that if the patient and non-sustained cardiomyopathy with ventricular tachycardia under the age of 50, it is the class 1 indication for genetic study. So I think closer follow-up of LV function or MRI might be helpful to estimate this patient's prognosis.
Well, it is unusual patient have, if you had history of drinking and caffeine alone, had the initial baseline left ventricular hypertrophy and imaging, yet 12-lead EKG doesn't show left ventricular hypertrophy. So there's some discordant clinical data that is a little bit of a concern. So that's what the Dr. Bach pointing out. So that looks like LVH continue to persist, despite that you had heart failure therapy and all that. So I think it is important to start thinking why the clinical spectrum, why the patient is not responding to the usual treatment. Then you need to start thinking out of box a little bit. Okay. Very good point. Okay. Anything else you want to show to us today? You still got more?
네.
Okay. Let's go.
오존센.
F에서
소리가 안 들립니다.
F가 확인이 되지는 않지만 투3 임페리얼리드가 마티브로 되어 있어서 페리엑스가 BBC로 사려고 LBB 모르지 사이드 나오는 BBC로 살
무슨 뜻이야?
와이드 QRS 앞에 APC로 직접 추정되어 있는 시그널도 있는 APC의 어버런시 가능성이 또 있을 것 같습니다.
So first of all, what's the rhythm, this patient? Baseline rhythm. Look at the P wave. Is it normal or abnormal?
피부 몰폴로지가 여러 개입니다.
P morphology가 여러 개라.
R이 좀 짧은 거.
PR이 왜 짧아? 그 설명이 되는 게 아닌가? 첫 번째,
Too short to be conducted.
yeah, fellows. So first thing you need to read anytime EKG, look at the sinus, whatever P wave first. You need to look at the whether baseline rhythm is normal and abnormal. That's first thing. Then you look at the PR interval. Then you look at the QRS complex. Then you look at the QT interval. That segment, all that. That is important. How to you read the systematically your EKG. Otherwise, you will miss things. Okay? So you need to make a habit of it. That's why we are teaching you guys to read the ECG. So what's a PR interval of this patient? What's a P wave? Let's go first, that one. What do you think about the P wave? It's a normal P wave, abnormal P wave? You lead it to might be something that you can look at it, follow along the line because it says a continued rhythm is tracing, right? So then what happened? Your P wave, that looks pretty same, right? And then after PBC, that thing disappear. The following next beat, take a look at it. You don't have a really very, very visible P wave, very tiny portion of it. The next one, even worse, almost no visible P wave. And then you have another PBC. And then follow that pattern continues. Okay. So what were you saying here? So you got a P wave, that PR interval is changing along the line here, gradually going into the QRS complex. That's what we're describing, right? That appears to be interfered by PAC that you're describing. But the PAC morphology is different. That one, next one, even next one, right? Not same, at least in my eye. So what were you trying to say here? This rhythm, basic rhythm is what? Sinus or different kind of rhythm? At least what we can say, there's a P to QRS relationship is 1-to-1, except the PR interval change. P of X is unusual pattern, right? And your PR interval is very short. So what is the definition of a junction rhythm in the standard class EKG teaching? PR interval, whenever PR interval within 110 millisecond, we should consider junction rhythm based on criteria. So this could be topic atrial rhythm with isorhythmic dissociation, or maybe progressive dissociation, or could be junction rhythm. That's why your P wave is invert. Agree? Okay. Other morphologies what? So you have to discuss all that, right? Okay. So next thing that this book showing what? Your preceding P wave to next P wave interval changing. P2, P3, Dr. Peters described P6, P7, P9, P10, coupling changing. That does what? Any other?
What does it say, the retrograde activation of atria?
Oh, that's because of P wave is inverted. It's not saying
Because
this
here
is
and
junctional. Yeah, so P wave coming from bottom to top instead of its normal sinus activation. That's what he's describing. Okay.
this is typical example of isorhythmic AB dissociation with some premature atrial beat with different morphology. Am I right?
One possibility is that. The other, but yeah, we have to explain why the P wave inversion also, right?
Okay.
It's not sinus rhythm. So that's what we discussed. Could it be ectopic atrial rhythm or could it be a junction rhythm? Because your lead one P is upright, AVL upright, AVR is upright. So clearly coming from bottom to the top. Axis is consistent with the possible junction rhythm, but is interacting with the PAC as resulting. So this is an aberrancy or this is a PVC, gentlemen? Why the complex? Is it PVC or is it aberrancy?
네, 에버런시
Is by chance the probability is aberrancy would be probably higher than PVC, right? Because of your preceding P, everyone has a P wave.
But if you look at the P3 and P7, the PR interval quite different,
Change it, right?
right?
Why? What's the mechanism PR interval can change it can cause aberrancy?
So we can exclude the potential coincidental the PVC.
Right? Then, but you could also evoke the possibility of first of P7, PR intervals very short, right?
Right.
The question is there is any supernormal conductions or other possible mechanism there involved. Because preceding coupling interval, P2, P3 different than P6, P7. Make sense? Because if you're fixed, then your argument is correct. But when you vary PP interval, then because the PP intervals differ, P3, P2, P3, P6, P7, P9, P10, they're different. They're not same. So this is probably, if we read this, a lot of people talk about that, these mechanisms, but I would argue that probably patient underlying rhythm, junction rhythm. And junction can vary exits, QRS complex following different coupling interval. So that's why we define junction rhythm P R interval less than 110 milliseconds. And could it be inside, it could be outside, or even follow sometimes. but interaction of that is important. Okay. So what is it describing in there? Why he has a couple of errors in the each QRS complex? He's describing as an aberrancy with different interactions. You know, for me, it's not fair for me to comment this decision because I had discussed this case with Tom before. So question is that is he conforming this to a fascicular escape rhythm? If that is an argument, what fascicle is causing this PVC? Is a QRS complex is what? Lap bundle pattern, right? Is a lap bundle pattern. So where this thing coming from? It's got to come from right bundle, if that's the case. Is my argument it was that can you conduct right bundle that fast to be a PR this short? And his argument is not a evidence. He thinks that is a fascicular escape rhythm because of reset.
Okay, I understand, but it is too complicated for the Saturday morning conference.
It's okay. It is something to think about it, but because of I had some complaint from juniors that the book is too difficult to read. I think it may be possible, maybe not, but anyway, I am making digital copy of another book, easier to understand this mechanism first. So you guys will get that soon. Hopefully you can collaborate together and then read it. That may facilitate understanding this complex arrhythmias. Okay. So you understand the drawing here. So junctional rhythm is based on underlying rhythm. Okay. Intermittent PAC interacting with the junction and then basically resetting the mechanism of rhythm. And that, his argument is that QRS complex is changing a little bit as well. That's his QRS width is vary also if you look carefully. Okay.
네.
Long comment.
얘기해 주신 내용들이 다 사실 여기 정리되어 있어요.
Right. But you need to read it about it. So you gotta take the time to read about this, otherwise you can really.
그럼 다음으로 넘어가도록 하겠습니다.
Okay.
녹화 끄셔야 되잖아.